Welcome back to the Diet Doctor Podcast. I'm your host, Dr. Brett Scher. Today, I'm joined by Dr. Kyeremanteng. Now, he is a pretty remarkable guy. He's an ICU, an intensive care unit doctor in Ottawa, Canada. But he's also got a Master's of Health Administration. He's a podcast host. He runs the Resource Optimization Network, which is a research institute with the goal of transforming healthcare and optimizing the use of healthcare resources. And he is a really passionate and powerful voice that I think really deserves to be listened to. We talk about a number of different things in this episode, including COVID. I mean, he is the epitome of a frontline COVID worker, and his take on metabolic health and prevention of severe COVID infections and the importance of metabolic health is an important message that I think we all need to hear. And also, Ottawa is doing something really well with COVID because he actually mentions that he hasn't seen many cases lately because they've done a good job of preventing it. But also, we talk about so much more than that. I mean, we talk about low carb. He's sort of new to the low carb space, but what he sees as the benefit of it and how sort of his eyes were opened by it. And we talk a lot about race and ethnicity and socioeconomic class and how that impacts healthcare and sort of the steps that need to be taken to break that down to reach more people and really spread the message of health promotion to prevent disease and promote health for all of us, not just those who can afford it, not just Caucasians and upper socioeconomic classes, but for everybody. So we kind of run through the gamut here, but I really think you're going to appreciate his enthusiasm, his passion, and his message. So enjoy this episode with Dr. K. Dr. Kyeremanteng, thank you so much for joining me on the Diet Doctor Podcast today.
Brett, I got to tell you, this is a true privilege. I've been jammed up and excited to do this for a while, so thanks for having me.
Well, I've got to say, I've been looking forward to this because every time I hear you speak or watch a video, your energy is like so palpable that it just pumps me up. So I thought, wow, there's going to be something about this interview that will bring it up a notch in the energy level, I think, with you. So that's pretty awesome.
I love it. Thank you, buddy.
But you're not just about energy. So let's talk about you a little bit. I mean, you are an ICU doc in Ottawa. You have your own podcast. You have your own research facility or research institute where your mission is to no less than just to transform healthcare, which isn't exactly a small mission. You're a pretty motivated guy here. Tell us a little bit about your journey and kind of how you got to this point of wanting to do your own podcast, having a voice that you want to be heard, and having a mission to really impact healthcare.
Oh, great question. Thanks for that, Brett. Honestly, it came fairly early in my career where you would see how inefficient our healthcare system was and the deficits in the healthcare system. And I give this quick story about a young trauma patient that was trached, that was heavily reliant on getting chest physio to try and improve his oxygenation and so on. And we go into a long weekend and it's an era of cuts. And so on the long weekend, doesn't get his physiotherapy and ends up back in the ICU because of mucus plugging and inability to clear his own secretions. And I remember thinking to myself, this is absolutely wrong. Like to think that we are cutting in areas that we know are beneficial, like we need to do better. And so my whole area of research, I looked at ways of making healthcare more sustainable. And so we formed this resource optimization network, and we've been productive. We've been producing these papers and really proud of our group for doing this. It's a multidisciplinary team. And honestly, nothing was changing, Brett. Like we were saying, hey, this is some evidence-based practices that are going to help reduce spending and improve the well-being of our patients. Like what's happening? And so we thought, maybe we got to change gears a bit. So we started our podcast, Solving Healthcare, and we thought, hey, you know what? Like shows like yours that are able to vocalize and express these novel ideas to people and have a bigger reach. Like nobody's reading the Journal of Intensive Care Medicine. That like my neighbor's not reading that, right? But they might be on Twitter. Everyone listens to podcasts. So we thought, hey, like let's get that reach. Let people know where our deficits are, what is working, and motivate people to get things moving. And so, yeah, we started the podcast about a year ago, and my life has changed ever since. It's been incredible.
Yeah, tell me how your life has changed.
Well, it's in so many ways. For example, I'm meeting you for the first time today, like somebody I've looked up to for a very long time,
Thank
and
you.
but we start seeing more conversations are having, at least locally, about some important issues like, you know um, we've interviewed people such as child psychologists, right, where we know childhood well-being, their anxiety, depression is increasing, and so we talk about ways that we could address that. And through that, there's been some initiatives. We had a charity called Bridges Over Barriers that started, and it was clear to some of our listeners that if we were to invest in kids that are in need, like this would be a way of them getting past some of these obstacles. And so we started this charity, raised almost 70,000 so far.
Great.
That's one example. I'm trying to think of other things that have changed my life. I've given me a platform to talk about so many important issues, including obviously we're talking about a low carb and keto summit we've done. I've been quite active locally about Black Lives Matter and anti-Black racism. Um, I've recently been appointed on a board of our children's hospital, which would have happened without the podcast. And so, like, really, my life has changed in such a good way, and I feel like our reach is so much more now.
Yeah, and I think that shows just how important your message or messages are. And you have a lot to say about a number of different topics that really hit home in a number of different ways and are timely and are prescient and so needed. So I think that's why you're seeing these doors open, which is wonderful. Now,
I
now
appreciate
you
that.
mentioned the low carb summit. So you were an ICU doc working in the intensive care unit, seeing the
Mm.
sickest of the sickest patients on breathing tubes, needing medications to support their blood pressure. I'm sure you've seen a ton of COVID patients, and you've done a number of episodes on your podcast about COVID. But
Mm.
then here you are doing a low carb summit. So tell us about what brought you to the low carb summit, what inspired you to do it, and how that sort of connects to your medical practice.
Yeah, great question. So it was very clear early on in my dealings in the pandemic, in the intensive care unit, that the risk factors of obesity, type 2 diabetes, hypertension were real, absolutely real. You
Mhm.
know, almost to the point where I even felt, and this is anecdotally, just from what I was seeing, that even more so than age, if people had these poor metabolic health, this was an issue. And so, and I still remember one of my first patients was a guy my age. He was type 2 diabetic, but very functional family man, and he was so sick. Ended up on the most amount of oxygen we could provide. Needed to be on dialysis, and I remember looking at our team. This is in the beginning of COVID. And I'm like, we can't lose him. Like this is crazy. This is scary.
Mhm.
And you go back weeks afterwards where things start to settle down, and you look at what brings people here, and it's the risk factors. And I remember talking to a colleague, and I'm saying, like, now that COVID locally in Ottawa, timestamp it, it's August 12th when we're doing this, or it's August 13th, when we're doing this interview, that there's very low incidence. Like, for example, in our ICU, hadn't seen a case in over 3 months.
Oh, wow.
And yeah, exactly. And I'm telling myself, why are we not sending a message to the public that if we get healthier right now, you will can reduce your risk of getting sick from COVID-19? And and just to put some context into Brett, like, I'm new to the nutrition space. Like, I'm not low carb, I'm not keto, I fast. That's maybe I've been doing that for 2.5 years, and then I'm learning about this stuff. I'm learning from you guys. I had Ivor on the show, um, and I'm learning that you can reverse and keep in the context of this too. Like I'm 15 years out of medical school, and this is new concepts to me. You could get people off their antihypertensives, their diabetic meds in weeks, and I
Yeah.
had no idea. People telling me this, I'm like, what? And so then you go and you look into this, and I'm like, this is an opportunity. Are you kidding? Like when, especially locally where COVID has settled down, like in terms of, sick patients coming into hospital or in the intensive care unit, I'm like, man, if this is a story, let's preach this. Let's get our patients healthier, metabolically sound, and we could do this in weeks. How is this not being screamed to the world?
Yeah.
And once again, I get paid when more patients I see, I get paid. I don't want to see sick patients. And this is such an easy, efficient way of and sustainable way of getting people healthier. It baffled me. So then because of this, I'm like, let's do our part. We'll have some guests on the podcast to talk about this. Let's do a low carb summit, and really inform the public on ways that and on why this works. And this is like my mission right now, amongst many,
Yeah.
but this is a big mission of mine right now.
I
Spread the
love that
word.
enthusiasm. I mean, that's what we need, that eye-opening enthusiasm of, well, how did I not know this? And look at the impact we can have on people. But it's also the surprise. And that's the surprise that so many doctors go through, to say, like, how is this not taught to me? How is this how were we basically taught the opposite of this, but here's this powerful intervention. And I need to touch on something you said, that you said you get paid the more patients you see. And that's sort of our system, right? The sicker the patients, the more patients in the ICU, sort of the better it is for the hospital and the better it can be for the doctors. But that is the exact opposite incentive that we should have. We should have this incentive to keep people healthy and keep people out of the hospital.
Absolutely.
And I assume that's part of then what you're doing in your mission to kind of revive healthcare and completely revolutionize healthcare, is focusing maybe more on the prevention. Is that something that you're trying to work on?
Absolutely. Because people have no idea how costly coming into the intensive care unit is, for example. So if I were to tell you 1% of your gross domestic product goes to treating critically ill patients, like that, like 1% of a lot is a lot. Okay. And to think that we could be, and I'm sure it's similar in the States where, our baby boomers are getting into prime time usage of healthcare. We're always looking at ways that we could make it more sustainable. And yes, I get paid more patients I see, but I don't want to see you. I really think, because when you come to us, it's not easy. We put our patients through a lot, and their outcomes aren't as good as people think. Like, we might be able to salvage your life, but functionally, the person that you come out of your intensive care admission, like you're disabled, like mentally,
Yeah.
physically, emotionally, PTSD, like all these bad things. And like, we all got into this game of medicine to help people. And honestly, I don't think we talk about it enough, how we can prevent you from walking in our door. Like,
Yeah.
really save it for the people, like reduce the amount of people coming through, because if you need to come through, it's not an easy road. It's a difficult road. And so I just really wish that, in terms of even our studies, if you look in my world, the critical care world, nothing's on prevention. It's all about, what are we, this approach reduced their days on the ventilator by 0.6 hours. You know what I'm saying? Like, let's look at real outcomes. Let's
Yeah.
think of measures that's preventing people from walking in our door. I don't know.
Yeah, it's a great perspective, and especially because, I mean, look, I remember when I was a resident and a fellow starting out in cardiology, and it was magical. The things you can do in an intensive care unit for people who are basically almost dead, and you can revive them and give them their life back. It's sort of magical, but what you don't necessarily see is the life they're returning to is far from the life they started with. And that's exactly what you were just alluding to, the months and months, if not years, of physical therapy and emotional therapy, and they may never get back to the point that they were. So even though their life was saved, their life was dramatically changed. So if you can prevent that, It's so much more powerful. So since we were talking about COVID and the definite risk factors of hyperglycemia and diabetes and obesity that worsen outcomes, I mean, we have the evidence to support that. We don't have the evidence to say that any preventive measures for lifestyle can therefore prevent COVID just because it hasn't been studied. But do you
Yeah.
think it just makes sense that if we could get people to focus on metabolic health now, get them to reverse their metabolic syndrome, their prediabetes, their diabetes, that we would see a fraction of the people in the ICU that we do now here in the United States and in other countries that are still seeing an uptick?
Yeah, I'm so glad you brought that up point because as you brought it up, Brett, like it isn't an evidence-based uh recommendation, and it's just because it hasn't been done. But
Right.
everything in the ICU is all about inflammation. It's all about we see our patients that are diabetic. Like aside from COVID, you come in obese and diabetic, hypertensive, you do worse, period. Whether you have ARDS, which is acute respiratory distress syndrome of the inflammatory lung, if you have a severe infection like septic shock, all these are risk. You being metabolically poor all results in poor outcomes. So even if I'm wrong here about COVID, if we're all wrong about improving metabolic health, you are still preventing other diseases, cancer, heart disease, all these other things. So to me, the narrative, with COVID, there's so little downside to adding that as the part of the narrative. I don't see why we're not doing it. And
Yeah.
so I that's where I come from. Like because I think we do talk about evidence based a little bit too much, and in the sense that like there's even in ICU, like not every single intervention we do is 100% evidence based. There's still that art element of treating our patients, but this something like this where the downside would be, I mean, I can't really appreciate a true downside of bringing up that message. Unless
Yeah.
Brett, I don't know if you could think of a significant
No.
downside.
I can't really, but I guess if someone was going to dramatically try and change their lifestyle and start fasting and start a keto diet, like when they are first acutely infected, you could say maybe that's too many changes going on in your body at once and too much stress at once. But to do it from a preventive standpoint,
Yeah.
when you're well, to say, put myself in better condition if I do get this infection or get in a car accident or get septic shock or have open heart surgery or whatever the case may be, if I can get rid of my metabolic syndrome and lose 30 pounds and improve my diabetes, my type 2 diabetes, and obviously you are in a better condition. And
Yeah.
there's plenty of literature of people who are in the hospital, especially like after cardiac surgery, and they do better when their blood sugar is under control. So
Right.
everybody who comes out of the operating room after heart surgery is put on insulin of some sort to control their blood sugar, but they're also getting maybe IV fluids with sugar in it, basically what we call D5W or they're getting enteral feeding where they're not eating yet, but they have a tube put in and they're getting sort of a high carbohydrate type feeding.
Yes.
So it's like we're driving their blood sugar up only to give them insulin to bring it down. So I guess my point of bringing this up is there a better way potentially? And can patients sort of be their own advocates? Like, could someone come in and say, hey, I don't want sugar in my IV fluids because I'm low carb and I burn fat for fuel? And if someone said that in the hospital, would the surgeon or the ICU doctor sort of look at them sideways and say, what are you talking about? Don't tell me how to do my job. Like, what do you think about that whole concept
Yeah.
of a low carb patient sort of advocating that way for themselves?
I love that question. So to start with, in terms of what we're giving our patients. So once again, I'm new to the nutrition space, and when I looked at some of the stuff that we're giving, like enteral feeds, so feeds that are from a tube going into the stomach, as you put, a lot of glucose, a lot of seed oil in there, and like I said earlier, everything is inflamed in the ICU. You're there because of inflammation. So I find it actually quite eye opening when you look at the content of what we're giving our patients. And so actually we're actually meeting tomorrow, one of our small research group and our nutritionists, because there are some enteral feeds actually that are low in carb, more high in fat content, and asking ourselves maybe this might not be the right thing, especially too, like we also give our, when we feed in the ICU, it's 24 hours, right? Like it's not feeding during your normal circadian time. And I'm not sure where this
Right.
background, where this came from. And this is a place where delirium is high, poor sleep is high, um, and it might be one of those things, like medicine's slow to adapt. Like it might be one of those things that this is the way we've done it, so this is the way we're doing it. And so, like getting to your question of if a patient were to ask me, like I'm fat adaptive, like why are you giving me this? Is there other approaches? For me, I mean, I'll tell you this much: most docs are going to be looking at you like you're sideways, like something's wrong with you, right? This is not. They're not. Most docs aren't attuned to this. My personal bias is, unless you could, if I know it's clearly going to harm you, that's one thing. If I don't think it's going to harm you and we can mutually agree that we're on uncharted waters, I'm okay. You know, and I I don't know how much options you truly have with when you're in the intensive care unit, but I do think personally, if you're coming to the hospital, especially you had your operation, your post op, you're relatively improving, and you ask yourself, do I really need to eat what's on this tray, or I can't see why you shouldn't do that. You know what I'm saying?
Yeah. Yeah, I think that's so interesting because I do spend a lot of my time trying to help people communicate with their doctors, but it's all focused on an outpatient basis. And I hadn't really thought about it or talked to many people about what happens when you're in the hospital. How do you communicate with your doctor if you're in the hospital? And it's going to be difficult, like you're saying,
Hmm.
because people aren't used to that, and people have their way of doing things, and docs don't always like to think outside of the box. So
Hmm.
I don't know, is there any advice? I'm putting you on the spot here, but any advice you could give to somebody to kind of make that conversation a little bit easier and to try and make that ICU doc or that surgeon sort of think, okay, maybe I do need to step outside of my bias here and listen to what this person has to say.
Yeah, that's a great question. I think the way I would approach it is always in a lens of like it's like a mutual discussion. It's like a non-confrontational discussion. It's, hey, this is what I know about this. When I look this up, I know I'm playing Dr. Google here or what have you, but just to be clear, like I'm fat adaptive, and this is where I would like to try. Can you think of any downsides of me trying this method of getting providing nutrition to my body? And I would say most docs, when you can clearly illustrate that there's probably no harm in you trying and that you understand what the risks are, most docs would be open to things, but you're going to have resistance for
Yeah.
sure,
But
nine
like
times out of 10.
I like the way you said that though. I think that's probably the take home is saying, "Listen, help me. Can you see any downside to this?" Not like this is what I'm doing.
Yes.
Prove to me there's no downside, not the confrontation, but like help work with me. Can you see any downside to this? I like that approach. I think that was a
Yeah.
great suggestion. Yeah.
Thank you.
All
My
right.
wife's a psychologist, so I'm always like learning from her.
Isn't that interesting, right? Like how psychologists might teach you to communicate with your spouse or with somebody else. It's the same as communicating with your patient. It's the same as patient communicating with your doctor. It's just humans communicating with humans. So it's
I
all about
can't.
how you phrase it.
Oh my god, I can't count how many times I've learned from her, and it's literally affect how I communicate with patients. Like when they're frustrated, and to one of the key things is to like really bring up the emotions. This is one thing that Kathy, shout out to my wife, really has helped me in terms of dealing with patients, because I also do palliative care too. It sounds like you're scared, sounds like you're angry here. Like, tell me more about that. Like, and it's all about creating rapport too, right? And when you have that rapport, you have that trust, everything is better. And so shout out to my wife there, Kathy. Couldn't do it
So,
without you.
Sounds like she's done a good job. She's taught you well. That's
Yep.
good. So while we're on the topic of metabolic health and trying to focus on prevention, as you're looking for ways to optimize healthcare and to do research and to really have your platform, why do you think there's such a barrier to focusing on prevention and to focusing on metabolic health? And it seems like hospitals and healthcare systems may sort of say they're interested, but there's really a barrier of making it a top priority. Why do you think
Yeah.
that is? And what can we as everyday people sort of help to break down that barrier?
Yeah. That's a tough one. Like, I think in terms of hospitals, like, depending on if you're in the States, especially, the more patients you see, the more money you make. The sicker you are, the more money you make. And it's a lot of these places are for profit. And when it comes to pharmaceuticals, when it comes to the industry, there's when you could take a pill or three versus change your diet, there's not an incentive there. There's not that platform. That's one barrier. The other barrier too is, and and forgive my ignorance to a certain degree, but when it comes to these studies, when it comes to nutrition, I personally find that they're all over the map. Like, it's really
Mhm.
hard to really know what's what, um, based on not only the end result, but the quality of the studies. Like, a lot of
Right.
these studies are often uh, like surveys, so it's based on memory, and like, how
Mhm.
reliable is that? It's not too many RCTs on that on a lot of the concepts that we're talking about. And so I think from the medical point of view, or for among clinician, you're preached to the death, like, evidence-based, evidence-based, evidence-based. And especially, I mean, I'm thinking about you in your world in cardiology. Like, I mean, everything is RCT, and patients of like thousands when you're looking at things. And so I think that's our world. And so I think that's a barrier too. But I think
Yeah.
what needs to change is, you know, uh, I'm wondering if there's a lot more opportunities for more rigorous studies. Like, now that it's becoming more and more known about the benefits of some of these methods, like low carb and keto. I think also the continued testimonials, like, in like, because you gotta speak the language of your crowd. So, like, us docs, yes, you need that evidence base, but the our patients, our family, when they see the stories, when they see Barry from across the street lost 30 pounds. Like, one of the stories that I loved was when I was partnered when that's COVID patient I was talking about earlier, the really sick one, the diabetic one. One of my colleagues, he had that poor metabolic profile. Another intensivist. He saw what we saw, and he's like, "This is not going to be me." He lost 30 pounds mostly through fasting and a bit of low carb, and and we all see it. The nurses
Yeah.
see it, his family sees it, and the amount of people that approach him talk about, what did you do? And talk about fasting, talk about low carb. And that was just such a beautiful trigger to start the dialogue and people to see it. I actually put him on the show just to say, like, hey guys, this is a guy that took it seriously, and now he's improved his metabolic profile significantly. And so, you know, depending on your crowd, testimonials, and I do wonder if there's an opportunity still to do more rigorous research in terms of low carb and keto. But I'm still learning. I'm still trying to get my head around some of the studies.
Yeah, you bring up a lot of good points there. I mean, you're right. Nutritional science is all over the map, and especially when we rely upon poor quality nutritional epidemiological studies
Mm,
and with the healthy user bias and food frequency questionnaires with inaccurate recall and tiny hazard ratios, and
hmm
but yet somehow that gets pumped up to being sort of definitive evidence of proof one way or the other, and gets written into guidelines when the strength of the evidence doesn't really support how loudly maybe people are screaming from the rooftops about these results. So I
mm,
think that's a great point, and that's confusing. That definitely is confusing. But then I love how you brought that back to leading by example. That doctor was leading by example, taking charge of himself, and other people take notice. Because let's be honest, like doctors, when it comes to health, doctors are in a leadership position, whether you want to be or not. How we live our lives personally, how we represent our health personally is noticed by patients, is noticed by others. And
Absolutely. Like,
yeah,
how
like,
ironic is it when you're getting a diet advice from the 250-pound
hmm,
family doc? You know what I mean? It's like, oh, you should be losing weight. I'm like, what?
yeah,
Like, like, and you're giving me advice right now? And the beautiful thing about when us clinicians, leaders, are doing this stuff, like we're not, the beautiful thing about being in this position is so many people, like we're under the lens of so many people, our patients, our family, our colleagues, they all are seeing what's happening, and that's motivation for a lot of people. And
right,
so I do, I mean, I won't lie to you, like a lot of the stuff that we're doing is motivated to get our healthcare team healthier. Like none of us want to get sick from COVID. None of us want to, we saw what has happened in New York and Italy. And when I got a colleague that's saying, "Hey, I heard you're doing this summit," I'm sitting down and telling them why, and trying to get in their ear and say what the benefits are and why we all collectively, especially as healthcare providers, could be an example and protecting ourselves.
right. Right. Now,
Mm.
I've got to get back to this. You said you haven't seen any COVID patients in the ICU in months. What are you guys doing there that's working so well? And because we obviously need a lot of help here in the US. So
Oh my
tell
God!
us what to do. What are you doing that's working?
So it's that's a very it's tough to put a finger on it, but I think the number one thing that benefited Canada is that we saw what was happening in the rest of the world before it hit us.
Hmm.
So Italy, New York, Washington State, all were getting hit, and we were preparing beforehand. So like, we already locked down really early. We put in measures. Our hospitals increased capacity. We're doing all these things, and then we didn't reopen until the curve, like the curves were downtrending. I think that was one of the key things that, in my opinion, led to the success of what's happening in our country. And I mean, there's a lot of theories, and I don't know what's what, to be honest with you. But hearing the experts on the show about population density, like we're the we're I forget, second or third largest country in the world, and we have the same population of California. I think
Right.
that
That's a good
also
point.
helps us. But honestly, I think it was just the main thing was that we had time to prepare based on seeing what other countries were going through.
Yeah. Yeah. I think population density really does have a lot to say about that. And I
Yeah.
remember you could look at the map of the US where the cases were, and like Montana and Wyoming always had like the lowest cases. And
Right.
I've always had this fantasy of becoming a rancher out in Montana and Wyoming. So when COVID hit, I was like, now's my time to go be a rancher out there.
It's a
And
beautiful part of the world too.
oh yeah, for sure,
Yeah.
for sure. All right. Well, I want to switch gears for a minute here because you also, I mean, you've got such a fascinating story from so many different levels, but sort of your background as a person. I mean, your parents um, came to Edmonton
Mm,
from Ghana,
that's right.
and you grew up then in Edmonton, and you have been very honest and emotional on your podcast about facing racism growing up
Mm,
and how you had to fight through that, and some specific examples with your father. And now here you are in a position of leadership, not just for medicine, but also for racism in healthcare, racism in general, and how to sort of help break down barriers to Black communities, to lower socioeconomic communities, to underserved communities. So tell me a little bit about your journey from that standpoint and what you see as a good way to help people um, start to sort of break down those barriers to reach those communities for preventive care and for better health care.
yeah. And thanks for bringing that up, Brett, because it's something that's very close to my heart. And after the George Floyd killing, it brought so much emotion back. It brings back all the trauma you had as a youth, being called the N word on ice, being, jumped on by older kids and being called any name that you could think of. Um, and it was so hurtful. It was so anger provoking. And at the end of it all, I remember telling myself, I haven't done enough. Like, I really haven't done enough. I'm one of the very few Black doctors in my hospital. Like, I'm in our hospital, the Ottawa hospital is one of the largest hospitals in North America. And I could think of maybe half a dozen Black docs. And I remember thinking, there was a patient I was just walking through the ICU, and there was a Black patient, and he's a young guy, and he looked towards me, and he asked the nurse, he's like, "Is that guy a doctor?" And he's like, "Yeah." And he's like, "Wow, that's amazing." And I remember
Wow.
thinking, "Oh, that's good pride, a little bit of a role model or whatever." But then I was like, "What the hell, actually? Like, why should that be surprising that a Black man is a doctor in this hospital?" And so I really got motivated, Brett, to do my part. And part of it was just telling my story and just really illustrating what the struggles were, not only being called names, but always having to take that extra step to prove your worth. And this might seem extreme to some people, but when I look at my colleagues, I look at the journey that I've done to get to where I am. There's always been extra steps, always extra steps. And so I think, as someone that got to be in a respectable position now, I feel like, hey, Black community, you could do this. You could be here. You could be in this spot. You don't look at me and awe and say, hey, it's cool to see a Black doc. We will need more of you. We need more of you to be able to treat other Black patients, and to have that better understanding of what it's like for them, because we know that whether it's COVID, whether it's other illnesses, as a minority, often the outcomes could be worse. And so to have that understanding, to have that advocacy, I just felt like there's a huge responsibility. And so now our group, we started a mentorship program for Black youth, which I'm really proud of. um, and anytime I have a chance to speak on it, I I I would always try and take up the opportunity, and just to let our youth know that you can do this. And
Yeah.
one of the key messages too is, the hustle is not easy. It's an uphill battle. But when you get here, when you go through that adversity, when you come out the other side, you are legend. You can handle so much. You will rise and be and accomplish wonderful things. And I think of that when I think of my boys. I think of that when I see other Black youth. And now I just feel like it's a responsibility. Because honestly, Brett, this sounds, to a certain degree, it might sound a bit extreme, but so many years you're just on survival mode. Like, you're just really on survival mode. You're trying to get through residency. You're trying to get through fellowship. You're trying to prove your worth when you're a new staff doc. But now is my time, and collectively it's our time to really represent and be that advocate.
Yeah, that's a wonderful answer, and really hits on a lot of different topics. I mean, you could think of whether it's business or whether it's medicine, sort of the more you have to overcome to succeed, kind of the more skills you have when you get there. And not just skills of, how to put in an endotracheal tube or how to start an IV, but skills how to survive in the world and how to interact with other people and how to rise above it. And those are such important lessons. And you can sense your motivation and your passion for teaching people that. And when it comes to helping people lead healthier lives, so they don't end up with diabetes, so they don't end up with metabolic syndrome and end up with the ICU with COVID or a severe infection, and trying to impact their lives, there are so many barriers when somebody is in an underserved area and lower socioeconomic class. And if we're talking about eating your grass-fed meat and your organic vegetables, and your organic cauliflower with your pasture-raised eggs, like, that message is that's just going to go right over their heads, because they're thinking, so many people are thinking, where's my next meal? Is it going to be a bag of potato chips, or is it going to be at the local drive-in? sometimes it can be sort of just too intimidating. Like, where do you even start when you're in survival mode? Where do you even start to help people start to prioritize their health and their nutrition? Like, what kind of advice can you think of to give people to start with?
Honestly, when you're in that situation, it's all about basic needs. It's like, I know we're different countries that have different philosophies in terms of, uh, level of socialization, but when
Yeah,
you don't have a house, a reliable income, you live in a poor uh in a poor environment, you got to grab whatever you could grab. So I think the first and most and important thing is to be able to have and provide through whatever means the basics: housing, knowing that you will have some form of income that you could not have to eat that bag of chips or whatever that's coming through the door. I think that's important. And honestly, I don't mean to skirt the question a bit, but when to answer your question directly, I don't know if that's where the focus should be. Like when it comes to nutrition, like I'm all about efficiency. I'm always all about like where we get the biggest bang for your buck. And I think when we think of people that are marginalized and are struggling to that extent, like I think what they're eating is a bit too, it will go under deaf ears. But people that are actually have the means, who are still eating the processed foods, that are still eating the fast food, that aren't getting out exercising, this is the market to me.
yeah,
But I do hear what you're saying, like, because they are obviously at risk too. But I think there's just so much. There's so many issues there before talking about the specific type of food, before getting there. So sorry, I'm not
yeah.
answering that directly, but
No, that makes sense.
honest
That makes
answer.
sense. If you're talking about like a teenager in that setting who's in basically survival mode, but then that teenager becomes the 25-year-old or the 30-year-old with the job, with the income, but they never got out of their old habits. Like
Bro,
that's
I
the
got you.
time to intervene. It sounds like from what you're saying, like that would be the better time
That would be,
to try and address that.
absolutely. And a lot of that too is like I always think about, who do these kids look up to? Look at who, like, role models that are being examples for, you know advocating for adequate nutrition, advocating for being active. Like, those are very formative years. You bring up a good point, actually, to be able to provide that information during those years, knowing that, like, I'm thinking of like a 15-year-old athlete, future hockey player, future basketball player, and some of these role models are saying that this is why I eat the way I eat. They're not going to forget that. Like,
Yeah,
my kids, that they see, I know it's mostly American fans, but Connor McDavid, number one hockey player around. If he's saying, yeah, this is the reason why I'm eating low carb, the boys are jumping on that train. you know,
sure. That's a
yeah.
great point. Yeah, influencers like that, and people who the people look up to, and if they're promoting taking care of yourselves in certain ways, people are going to notice. And here in the U.S., it's like LeBron James. You know what
Yeah,
he says is gospel, right? So, um, who is that hockey player
absolutely.
again? I'm not
Connor McDavid.
Connor
Yeah,
McDavid. All right, I got
yeah,
to look him up.
he's a legend.
Got to
Yeah.
educate myself in hockey. By the way, I like the Oilers flyer in the background there.
Yeah, you better
You're
believe it. But I hate to say it, they're out of the playoffs now, but we're diehard in this house.
Yeah, kind of crazy to see hockey going on in August, and with COVID. At least they're trying and they're getting it done. I guess
Yeah,
it's
the MLB is making me nervous though. I don't know if you're a baseball fan, but
oh yeah,
uh,
Padres all the way. Come on,
yeah,
but
that's fair
but yeah,
enough.
the teams having to so many teams with like what 14, 15, 16 positive tests in one team, and then having to shut down their games. And yeah, I don't think the season's gonna last personally, but I sure hope it does. It's nice to
Yeah,
have something, just a distraction. There's so much bad news, especially here in the US. There's so much bad news. And that's sort of, to me, that's the power of sports, to get your mind away from the bad news and get it on human achievements. And,
yeah,
we can still argue that athletes are paid too much money and they're put on too high of a pedestal, when it should be people like you, and it should be teachers, and it should be public servants. And, but but there's something to be said for entertainment and taking your mind off of things. And sports really plays that role.
I've been loving it. I hate to, like I don't know if that's politically correct to say it, but I've been loving the distraction personally. It's been so refreshing. If you think about all that we've gone through in the last few months, like it's been a beautiful thing to see.
Yeah, if we ever need one big, huge pick me up as a world, and certainly as a country, now's the time. Yeah. But it seems like there's such an opportunity to impact people's lives, especially when they're in underserved communities. But there's so many barriers in the way. So I mean, we need voices like yours, and we need role models like you to help lead the way. And that's why I think it's so great what you're doing with your podcast and with your research institute and with your job as a physician, and just getting your message out there and sharing your energy and your passion. And it may not be here's what you have to do, A, B, C, and D, and it all gets done. It's not that easy. If it was, we would have done it. But it starts with people like you and energy like yours. So thank you for doing that.
Brett, I really appreciate the kind words. And I got to tell you, what you're doing too, my friend, like getting the word out in a very clear, succinct message, it's powerful. And I really commend you for continuing to push this agenda. And I know deep down these conversations are going to impact. And I honestly, what I always have a bit of urgency when it comes to this, because I honestly, deep down, I think this will impact lives. I really do think that people will benefit from improving their metabolic health, whatever form, low carb fasting, keto, I don't care. But the fact that they're having these opportunities through these conversations, through these podcasts, through this platform, I think you're doing a world of good. And I gotta tell you, you got a good like interview flow too, buddy. Like as a podcaster, you notice these things, but you got like a good interview game, my friend.
Well, I appreciate that. Like, look, I mean, I always say it's the guest. If you're having a great conversation, like I don't want these to stop. I just want the conversation to keep going. And the thing I've enjoyed most about being a podcast host is just being to have these amazing conversations with amazing people. So thank you for taking the time to come on today. And I know you're in a lot of different things. So you've got your podcast, you're on Twitter, you've got a website. Where would you direct people to go to kind of hear more about you and hear what you're doing?
Thanks for asking, buddy. So solvinghealthcare.ca, you'll find everything. Our most recent online summit is Solving Healthcare /low carb. We're on Twitter, Instagram, YouTube at Quadcast, Facebook, also on Facebook, and our YouTube channel as well. So yeah, we're a bit all over the place, but yeah, don't hesitate to connect with us. And once again, Brett, this has been amazing. Thank you so much for this opportunity.
All right, my pleasure, Dr. Quadro. Thank you very much, and keep up the great work.
You too.